Welcome to Module 8 of our wound care training program, focusing on a critical and often challenging area: diabetic ulcer management. Diabetic foot ulcers are among the most preventable, yet potentially devastating complications in people living with diabetes. If not recognized and treated early, they can lead to prolonged hospitalizations, infections, and even amputations. That's why it is essential for all healthcare providers, especially nurses, wound care specialists, and primary care teams, to understand the right approach to assess, treat, and educate patients with diabetic foot ulcers. Over the next few slides, we'll be diving into evidence-based methods that can help improve healing rates and reduce complications. Let's begin. Let's begin by reviewing the learning objectives for this module. By the end of this session, you will be able to 1. Understand the pathophysiology and risk factors that contribute to diabetic foot ulcers, how they develop, and what makes certain patients more vulnerable. 2. Assess wounds accurately using standardized, clinically accepted tools and classification systems that guide appropriate treatment planning. Implement evidence-based wound management techniques, which include strategies for glycemic control, offloading pressure, effective debridement, infection control, moisture management, and even advanced therapies. And finally, we'll emphasize the importance of patient and caregiver education and the role of multidisciplinary collaboration in reducing the risk of recurrence and achieving better patient outcomes. These objectives are aligned with best practices in diabetic wound care and reflect current global standards. Before we dive into clinical techniques, let's understand the magnitude of the problem. There are over 34 million people living with diabetes in the United States alone, and this number is rapidly increasing worldwide. It's estimated that 1 in 4 people with diabetes will develop a foot ulcer at some point in their life. What's even more concerning is that over 80% of all diabetes-related lower limb amputations begin with a foot ulcer. These wounds are not just a physical burden. They cause emotional distress, reduce quality of life, and lead to significant healthcare costs. In fact, diabetic foot ulcers are one of the leading causes of hospitalization in diabetic patients. However, and this is key, most of these ulcers are preventable. That's why this module will emphasize early detection, comprehensive wound assessment, and a multidisciplinary approach that includes patient education, caregiver training, and consistent follow-up care. To understand how to manage diabetic ulcers, we must first understand how they form, their pathophysiology. There are 3 major underlying mechanisms that often work together to create a perfect storm. 1. Peripheral neuropathy. Diabetes damages the nerves, particularly in the feet. Patients may lose protective sensation, making them unaware of minor injuries like cuts, blisters, or burns. Over time, motor neuropathy causes muscle imbalance, leading to deformities like hammer toes or high arches, increasing pressure points on the foot. Autonomic neuropathy dries the skin due to reduced sweat gland activity, making it more prone to cracks and infections. 2. Peripheral arterial disease, PAD. Diabetes also damages blood vessels, accelerating atherosclerosis. This leads to reduced blood flow, especially to the lower limbs. As a result, even minor injuries struggle to heal. PAD may also cause cold feet, pain while walking, and delayed capillary refill, all of which impair wound healing. 3. Infection, chronically elevated blood sugar, impairs white blood cell function. As a result, even minor wounds can become infected quickly. Infections in DFUs often involve deep tissue or bone, osteomyelitis, and can be polymicrobial. If not addressed early, they can rapidly progress and necessitate hospitalization or surgical intervention. When these 3 mechanisms occur together, as they often do in people with poorly managed diabetes, it creates a situation where wounds form easily, go unnoticed, and heal poorly, making diabetic ulcers one of the most dangerous complications. Understanding these mechanisms helps us to target our treatment more effectively by controlling glucose, protecting pressure points, improving circulation, and preventing infections. Let's talk about why diabetic foot ulcers happen in the first place. There are two main types of risk factors: intrinsic, which are related to the person's health, and extrinsic, which are linked to lifestyle or environment. Intrinsic risks include having diabetes for a long time, poor blood sugar control, high HbA1c, peripheral neuropathy, meaning reduced sensation in the feet, poor vision, increasing chances of unnoticed injuries. Extrinsic risks are things we can actually change: walking barefoot, wearing ill-fitting or unsupportive footwear, repetitive trauma from poor gait or pressure, lack of regular foot checks, or access to podiatric care. Understanding these risk factors gives us the power to prevent DFUs before they start. Prevention always beats treatment, every single time. Accurate assessment is essential. Let's begin with the comprehensive foot assessment based on ADA guidelines. Inspect the foot for deformities, color changes, ulcers, and calluses. Palpate pulses and perform monofilament testing to assess sensation. Evaluate the patient's footwear for proper fit and protection. Next, during ulcer evaluation, focus on location and size, condition of the wound bed and edges, signs of infection, and whether bone involvement is suspected, like in osteomyelitis. To document and manage DFUs, use standardized classification systems. The Wagner classification is based on depth and tissue involvement, ranging from 0, no ulcer, to 5, extensive gangrene. The University of Texas UT system goes a step further by including infection and ischemia. These tools help in guiding treatment decisions and predicting healing outcomes. Let's now dive into the core treatment pillars of diabetic foot ulcers. 1. Glycemic control. High blood sugar slows healing and fuels infection. Collaborate with the diabetes care team. Reinforce regular glucose monitoring and medication compliance. Aim for an HbA1c below 7% if possible. 2. Pressure offloading. Pressure is the enemy of healing. Total contact casts are the gold standard. They distribute pressure evenly and promote healing. If that's not feasible, use removable walkers, offloading boots, crutches, or even temporary bed rest in severe cases. 3. Debridement wounds won't heal over dead tissue, so we must remove it. Sharp debridement is the preferred method, fast and effective. In select cases, enzymatic or autolytic methods can be used, especially for patients who cannot tolerate sharp methods. Each of these strategies helps set the stage for healing, like clearing the weeds before planting a garden. Let's now look at the remaining 3 key pillars of diabetic foot ulcer management. 1. Infection control. If an ulcer is infected, don't just rely on the surface swab. We need deep tissue cultures to get an accurate picture. Mild infections, topical antimicrobials might be enough. Moderate to severe cases, go for systemic antibiotics, guided by culture and sensitivity. Always assess for osteomyelitis. If the ulcer probes to bone, imaging and referral are a must. 2. Moisture balance. Wounds need just the right amount of moisture. Not too dry, not too wet. Use foam dressings for moderate exudate. Hydrogels or alginates for dry or highly exudative wounds. The right dressing protects the wound and creates a healing-friendly environment. 3. Advanced therapies. When standard care isn't enough, it's time to bring out advanced tools. Negative pressure. Wound therapy, NPWT, helps draw out fluid and promote granulation. Growth factors, bioengineered skin grafts, and hyperbaric oxygen therapy can help in non-healing or ischemic ulcers. These are especially helpful in stubborn wounds that haven't responded to the basics. No matter how well we treat an ulcer, it won't matter if the patient doesn't know how to prevent the next one. Daily foot care is essential. Wash, dry, and inspect both feet every day. Look between the toes, under the heel, and around the nails. Skin and nail hygiene. No soaking. It makes skin prone to cracks. Cut nails straight across, or better yet, get help from a podiatrist. Proper footwear is non-negotiable. Always wear closed-toe shoes, cushioned soles, and dry cotton socks. No walking barefoot, not even at home. Blood sugar monitoring. Encourage consistent glucose checks and compliance with medications. Early reporting is critical. Even a small blister can become a major issue. Patients should report any new foot problem right away. And lastly, quit smoking. It's one of the best things a person can do to improve blood flow and healing. Let's wrap up. Diabetic foot ulcers are not just wounds. They are complex, high risk, and demand early and ongoing attention. As nurses and care providers, you are the first line of defense. You detect the problem early, you manage the wound with precision, you educate the patient and family, and you help coordinate care across specialties. With consistent, compassionate, and evidence-based care, we can reduce amputations, save limbs, and most importantly, save lives. Thank you for your attention and for the critical role you play every day.